Welcome to Why Safety is the Key to Healing Chronic Pain. I'm your host, Leah Dawang, and it's my pleasure to be welcoming you all to the Provider Spotlight series. As we get started today, there's just a couple of things to note. Today's agenda will include a 30-minute presentation by Les, and then followed by a 30-minute Q&A. So should you have any questions that are specific to Les, go ahead and use that Q&A function. I'll be pulling questions from the Q&A function. So if you have questions for him, go ahead and use that. And then we also have one of our lovely program consultants, Sarah, manning the chat. Should you have any questions specific to the SSP or the Safe and Sound protocol, or anything else Unite related, you can go ahead and put those in the chat, and Sarah would be more than welcome or more than happy to help you. And with that, I'm going to head and share my screen. Lovely. And it's my pleasure to introduce Les Aria. Les specializes in treating psychophysiological disorders, functional neurological disorders, chronic pain, and medically unexplained conditions. His passions for mind-body interventions promotes a unique style to helping patients relate differently to their suffering, and thereby shifting them into pain recovery and wellness. Les has practiced for 18 years as a lead pain psychologist, helping redesign the chronic pain workshop curriculum at his clinic to incorporate modern pain science, mindfulness, and acceptance and commitment therapy. He's also co-founder and chief scientific officer of Emdr Health, a digital platform for pain recovery, and a member of the scientific advisory board for Curable, a pain psychology app. Les, it's such a pleasure to be introducing you today, and such a pleasure to have you here. And I think you said it best when you described your presentation as a clinical narrative of hope and transformation of healing chronic pain. So with that, I'll pass it to you, and thank you for being here.
Yeah, thank you, and good morning, good afternoon, and even good evening to wherever you're calling in from, and it's a pleasure. And let me get my slides up here. As you listen to the presentation, ask yourself, is it possible? And I often like to say everything is possible, and it requires a sense of hope for that matter. So let's go and start with this. Is the reason I entitled this presentation, Feeling Safe Enough to Heal. In my 18 years of working with patients with chronic pain, some complex ones and some basic chronic pain issues, what has transpired is that I've realized that the nervous system cannot heal, the brain, the body, the mind, it cannot quite heal until it feels safe enough. So in this presentation, I'll walk you through 3 major points. But before we get started, I'm wondering whether we could just take 10 seconds to just co-regulate. And for those of you not familiar with the Polyvagal Theory, let's just simplify it. Let's kind of stay connected with each other here. And one way to do that, if I could see everyone, I'm going to imagine I'm looking at everyone here, is I'm going to look through the camera eye, and I want you to go ahead and drop into your breath. So here's what I'd like you to do, just for about 10 seconds. I'd like you to look into the camera and imagine that you're looking at a bunch of folks in a group. And I'd like you to, as you breathe in, quietly say right here. And as you breathe out through your pursed lips, say right now. So the mantra you're going to use, or the soft mental note, as you breathe in, say right here. And as you breathe out, say right now. Let's do 2 more. As you breathe in, say right here with that in breath. And as you breathe out, say right now. 1 more time. Right here. Right now. Great. It's always good to get our nervous systems together, right? And so co-regulation is just a great way to have fun and safety and to connect with folks. So here's what I'm going to cover in today's brief presentation is I'm going to walk you through the latest and the greatest of modern pain science. Now, this is not Descartes' model. This is not the old pain way of looking at things. This is the latest modern pain science. I'm going to show you how pain develops in 4 stages. based on the latest research. I'm also going to talk to you through the lens of the polyvagal theory. Now, if you're not familiar with it, do not sweat it. I'm just going to simplify it in a single slide. So just know that, think of the polyvagal theory as the science of feeling safe. And there's a way of moving towards safety. And how I've worked with it is with chronic pain is using the polyvagal as a framework to get my patients out of pain. I know it sounds almost impossible, and I thought the same thing too. But I'm also going to show you my big tool I use. Now, I've been using this for about 2 years now and hundreds and hundreds and hundreds of patients. And I have some really clear evidence to show that why it works, and also to show you some barriers to the Safe and Sound protocol, which means that things that gets in the way of healing. So with that said, let me offer you the latest definition of chronic pain. When you think of chronic pain, we often think of it as a structural and nerve, but what I'm trying to get you to look at this is in a very different way. I want you to think of it as the nervous system. It's a software problem, not a hardware or structural problem. So what is the software problem? Sometimes when people are feeling overwhelmed, what happens is it activates the nervous system into a state of survival. So emotional issues can often get in the way of healing. May that be trauma, may that be a stressful life, may that be just how you function, where everything has to be perfect and you cannot get better unless this or that happens. So if you think about a new way of looking at chronic pain, realize that the nervous system is in service of your survival. And until we learn to work with the nervous system, it's almost nearly impossible to work psychologically with it. And you'll hear me say this a few times, where your physiological states really determines your psychological states, and vice versa for that matter. So let's take a look at the 4 stages of how pain develops. Now, if any of you are wondering where I got this information from, this is done through the great studies of Dr. Abkarian. Dr. Abkarian is at Northwestern University, and he has a great lab there with a bunch of researchers who've been studying chronic pain. Now, what you're going to hear is basically how chronic pain develops. Very often we believe chronic pain develops after an injury or years of fibromyalgia problems or because of trauma. But I'm here to show you something a little bit different that's based on solid science. So I want to show you that pain develops in 4 stages. So listen up carefully, because it's going to be a lot said in a short period of time. So one of the things I want to kind of walk you through is, believe it or not, is sometimes people have certain risk factors that predispositions them for chronic pain. That's right, predispositions. What's the evidence on that? Well, believe it or not, 1 of 3, if not all 3 risk factors, for example, ACE, if you're not familiar with ACE, ACE, Adversive Childhood Experiences. So that's also known for clinicians in the panel here as the Adversive Childhood Experiences basically means developmental trauma. So when there's early childhood trauma, it doesn't matter what kind of trauma. And so this could be also from being a family that's very demanding, a family that's emotionally not available. It doesn't have to be sexual abuse or physical abuse. It can be lack thereof, emotional support and encouragement. That can be developmental trauma. And believe it or not, trauma, no matter what stage in life, whether developmental or in adulthood through domestic violence, a car accident, doesn't quite matter. Trauma and or early chronic pain experiences alters the nervous system. So one risk factor is basically ACE, developmental trauma. Another risk factor is basically personality. That's right. When you are a pleaser and appeaser, when you are perfectionistic, when you are basically giving yourself up so you can actually receive love, that alters the nervous system. We have enough studies to show that when people go through trauma or lots of stressors, it changes the nervous system. It sensitizes the nervous system. You'll see how this makes sense as we move through the 4 stages. But the third risk factor, and I'll review all 3 shortly, a third risk factor is chronic stress, a life that's filled with chronic stress. We're talking stress in finances, unhealthy relationships, pressures at job, caretaking, child rearing. It doesn't quite matter what kind of stress, but the chronicity of stress is the danger of it. Stress is not bad, it's the chronicity of it. So let me review the 3 factors. ACE, developmental trauma, early trauma. 2, personality styles. We become who we become as a state of dynamic survival in that family system. So for example, myself, as I grew up in a military family, demanded perfection and excellence. So I'm a pretty nice guy, but I went through life fearing a lot of things that I needed to be perfect. So that altered my nervous system. And so when you have personality changes, that actually impacts your nervous system. So your family dynamics actually tends to bestow that personality changiness. ACE, adverse childhood experiences, developmental trauma, personality style, chronic life stress, that marinates this. When an injury happens, this is now we're moving into the chronic stuff, chronic pain. When injury happens, then that injury could be a physical injury or an emotional injury, doesn't quite matter. There's a death, there's a car accident, a slip and fall. When an injury happens, what the brain starts to sensitize itself. So the nervous system becomes very sensitive. It gets very good at practicing and producing pain. So in the third stage, what happens is this is less than 3 months. The brain will actually do one of many things. If there's a lot of fear and avoidance, and after about 2 months, 3 months, the brain actually senses danger. It really alters the nervous system. And when the brain and the body senses danger, your nervous system, when there's a lot of, I cannot stand this, and maybe during this time of healing after that injury, what happens is if it continues, your brain will actually shift locations of how it produces pain. Let me show you this. Is in the top part of your brain, in the somatosensory area of the brain, it tends to produce pain processing. That's where pain is processed. I want you to realize that when the pain does not get better because of fear and avoidance of wanting to move, I don't want to hurt, so I'm not going to move. And there's lots of fear about the pain, and there's lots of stress. The brain changes real estate locations into, this is the key part, into the emotional brain. Let me repeat that one more time. What transitions subacute pain, acute pain to subacute pain, which is the stage 3, and then into chronic pain, what shifts it is the emotional state of that person. Fear and avoidance actually tends to shift us into what we call now chronic pain. Now, what I want you to know is when this pattern occurs, we call it a learned neural pathway. Put it in simple English, pain becomes a habit in creating pain in service of protecting you. We have research to show now that when chronic pain occurs, it's an emotionally learned sensory input. So the more you fear the pain, the more it stays. And when you actually fear less of the pain through different interventions and mind-body practices, and even the SSP I'll be talking about shortly, you start to re-regulate how pain is processed in the brain, which leads to less pain. That's a lot said, and I'll take some questions as we go through towards the end of this presentation. Let me talk to you a little bit about the polyvagal theory and chronic pain using its lens. Now, this is a conceptualization of your autonomic nervous system. And for those of you not familiar with the polyvagal theory or just getting used to it, let me just show you how I'm using the polyvagal theory's framework to better understand chronic pain. So let's pause here before we get into this. Number one, you now have been told that this is a software problem. Pain is not about structural nerves or tissue damage. It's about the nervous system being in a state of defense, stuck in survival. Why? I just showed you that the brain can develop pain in 4 stages. This is based on brain science. And when there's a lot of fear around the pain, and or your life is filled with a lot of stress, and or there's unprocessed trauma, during the stage of this acute to subacute, and when it shifts over, the brain reallocates the way it processes pain into the emotional system of the brain. Now, what I want you to know is this is the key part that I really like about the polyvagal theory. It helps me understand how to get someone unstuck in the state of survival. So let's go through it real quickly. For those of you very familiar with the polyvagal theory, this will be easy for you. When we are feeling safe and connected, that's our ventral vagal. When you hear my tone of voice, or I wear a goofy smile, or you wear a goofy smile, and we're laughing together, and we're just enjoying and playing together, That's the nervous system that's basically saying is me safe. And the narratives of I can do all things. I have the ability, you're motivated. But when you're feeling overwhelmed in life and or with chronic pain, you tend to actually be stuck in the scared state. What is the scared state? It's called the sympathetic nervous system. And here's the part, when you cannot fight or flee from your chronic pain, or you cannot fight or flee from your life or life problems or relationships that you're dissatisfied with, what happens is this, is when you cannot fight or flee, your nervous system has a regulation system that basically drops you into a state of shutdown. Let me repeat that again because it might have been said too fast. When you are in a state of fight or flight, which is your sympathetic nervous system, you're feeling scared, you don't know how to get out of this problem you're in, and this could be the chronic pain issue. What happens is when you cannot fight or flee from a life problem, your nervous system has a built-in mechanism to shut you down. Now, many therapists know this as the freeze and collapse state. In the polyvagal, we call it the dorsal vagal system. What's interesting is this is where chronic pain lives. Chronic pain is basically a nervous system that's stuck, not just in sympathetic, but also in dorsal vagal. This is where you will find a lot of people spinning and spinning. They do all kinds of therapies. It doesn't mean that physical therapy is not good. That's not what it is. It's basically as whatever therapies, doesn't matter what form of mind-body therapies or medical therapies you're getting, when the nervous system does not shift out of these two states, it is nearly impossible. Hence, you have to feel safe enough to heal. And this is why most therapists sometimes don't get past this, is whatever we do, we have to re-regulate, retune the nervous system with the therapies and interventions we use. So let me walk you through what I use on a regular basis called the Safe and Sound Protocol, which is basically what I call the Polyvagal Theory in action, which is done through the Safe and Sound Protocol. Now the question is, why am I using this? I'm going to go back to the same statement. It's nearly impossible for anyone to heal until you feel safe. May that be trauma, may that be chronic pain, or any sort of chronic medical conditions. And by the way, on a passing note here, I do not differentiate between chronic pain and trauma. Why? Because they share the same neural pathways. And to put it most simply, chronic pain, trauma, doesn't matter what kind of trauma, it is one system called the nervous system. When the nervous system is very, very defensive, it is impossible to heal. Think about it. Would you want someone to teach you how to feel better when your life is very distressful and when there's so much going on? You just don't want someone to say, just breathe, right? It just irritates them even more. But the reality is this, is when you feel what you feel, that's a physiological state of defense. It's not by choice. So your nervous system does things to you on the inside to protect you. The problem is we try to fight with what shows up, and not having skills and how to relate differently to what shows up really gets us into trouble. Many of my colleagues, therapists, psychologists, and those practicing medicine find it hard to treat chronic pain because they use an old-fashioned framework. The framework I just offered you is the latest and the greatest because it shows you how to shift someone and to shift their paradigm on what is really the cause of their chronic pain. So if you're familiar with the Safe and Sound Protocol, that's fantastic. And for those of you not familiar with it, what the Safe and Sound Protocol is basically is music, that's filtered music. And it's basically music from the 60s, 70s, and 80s, great genre, right? And the thing that I want you to know is when you're listening to those cover band music, inside the frequency is modulated, it changes. And the cues it sends through the middle ear muscle into the nervous system, the vagus nerve specifically, what it does is they figured out how to send cues of safety. Think about it. When someone is yelling at you, what happens to your nervous system? We get defensive, we get constricted, right? When we're feeling kind of safe and playful, the tone of voice that we hear tends to be very soothing. So the Safe and Sound Protocol basically sends messages of safety to your nervous system. Now, traditionally, the way Porges developed this and researched this was a 5-day protocol, which is once a day, you listen to 30 minutes of the music in the morning, the filtered music, and 30 minutes in the evening for 5 days. Now, I tried that for many of my patients with chronic pain, and the attrition rate was really high. So people didn't want to do it. People said they couldn't do it for whatever reason. So what I did was, in collaboration with Dr. Porges, I talked to him about changing the protocol to fit my population, and I did. So I came up with something called the 10-day protocol. Once a day for 30 minutes, I usually have them do it in the morning because it's ideal for your nervous system before things kind of get in our way in the day, right? So once a day in the morning for 30 minutes for 10 days. And what's really intriguing is I have them keep a log. And we humans think we can remember everything, but we can't. So the log basically, after every listen, they keep a log. And the log is something like, what did I notice about my thoughts change, my emotions, my physical sensations, my body? Really interesting thing is this, very often when they show me the log before we dialogue about it, is I find out that as they're going through the days, the frequency is changing, is that they actually tell me how they're able to feel the sadness, the joy, and even the frustrations, but learning how to deal with it. In essence, if you think about the Safe and Sound protocol, it's an exposure therapy and a desensitization therapy, exposure and desensitization. And so how I work with them is when they feel what they feel, I make sure they use their breath to calm the nervous system down. In a sense, think about what EMDR does. EMDR, which is called eye movement desensitization reprocessing. EMDR is used for trauma. If you think about this, is when you can feel what you need to feel without fighting it, you reprocess the system in the brain, the nervous system, which then removes that fight or flight and shifts us into safety. I just want to show you before I wrap up here in the next few slides, I just want you to show you that a lot of my patients, I gathered some samples, some males and females that I see in an age range from 22 all the way up to 60s. And these are the common ones I treat. I use the SSP4, headaches, migraines. Look, and by the way, for those of you familiar with MUS, M-U-S, that's medically unexplained symptoms. Basically, they see a bunch of doctors from neurologists to pain physicians to, rheumatologists, and they don't know why they have the symptoms. They have basically autonomic nervous system where they overly sweat, they have unusual swelling of the eyes, just unusual physiological presentations. And the doctors go like, well, maybe it's psychological. And I get pretty upset about that. It's not psychological. It's your beautiful nervous system and defense. So with that said, I've treated a variety of them, even buttock pain, which is basically the piriformis muscle. And if you look on the right here on the side of the comments, the common thing you will find out is over and over again is whatever was emotionally overwhelming the person has basically dropped. I'll show you another slide specifically of 3 outcomes consistently I see, but I just wanted to give you some examples here, which I'm going to draw some attention to. My anxiety is better. I put their mental health problems, even the depression, their anxiety, and even their flashbacks had dropped from trauma. I often hear this, I feel released. It's almost like they had like a day at a spa. They feel a shift in their physiology. Remember, your physiological states determines your psychological states. And so you'll often hear the shift in their physiology, and they tend to hear in the comments the psychology of what the outcome was when they're feeling less defensive and they're feeling more what we call ventral vagal, feeling safe. Look at the bottom one for the buttock pain. I feel less fearful and I cannot be so bothered with it. And what's interesting is people tend to set healthier boundaries. They tend to do better with their treatments, with their psychologists, their physical therapists, greater medical compliance. But I want to show you 3 general categories, then we'll wrap up here with questions and answer session here. Is the first thing I wanted to draw your attention to is the top left-hand corner. Practically all patients with chronic pain report feeling less anxious. That is very true. I'm going to repeat myself again. When you shift your physiology, you shift your psychology. When people say, I feel anxious, it's really the nervous system in defense. And when you can lower the threat signal, you psychologically feel less anxious. This is with the Safe and Sound protocol. And again, the second thing I've noticed in all the patients I've treated, they tend to report less intensity in pain. So who is this best for? In my little time that I've spent in the last 2 years, I found out that the majority of patients who have complete remission, that's right, we're talking it goes away or it's barely noticeable, are three groups of patients. Patients with chronic migraines, for example, fibromyalgia and IBS, they seem to have resolution, which means they tell me literally, I no longer have the pain. That's pretty mesmerizing. That's pretty amazing, is what it is. But I want you to also draw your attention to the fact below it, as you can see, is it does work for some of the other chronic pain conditions. It lowers the intensity of it. But with this fibromyalgia, chronic headaches, migraines, IBS, it seems to resolve it. Now, these are people who followed the protocol. These are people who did other self-care issues, but it really, really promoted a great sense of resolution. I do want to draw your attention to the right side of the screen. A third category of commonality I get with people using SSP with chronic pain is this, is the biggest barrier. I've listed 5, I'm sure there are more, but these are the top five that I've come across. And what stops people from getting better when they're using the SSP? When they have ongoing chronic, SSP can help you, but when you're not dealing with your life in reality of relationship issues, if it's unhealthy, finances, structurally focused, which means that they still believe that this is not the nervous system, but no, I'm damaged. Protective mechanism is basically the pain is serving a purpose. That's right. It may be conscious or unconscious. I'm not saying they're malingering. I'm saying that it serves a purpose. I'll give you an example. When someone's on disability and they actually start to feel better, their brain, the nervous system will basically continue to produce the pain, even though they're telling you they're feeling better because they're fearful of losing the income or the finances. Unresolved trauma and personality issues tend to be barriers to the benefits of the SSP in resolving chronic pain or lowering the intensity. So in summary, people who use SSP with chronic pain feel less anxious, less intense pain, and overall, they tend to be greater commitment to their physical therapy, their medication treatments, if that's part of the plan, and psychotherapy stuff, like they're able to work on their traumas much easier and less fearful. So as I come to a wrap here, feel free to email me if you have any questions. I just want you to realize that I've said a lot in a short period of time. I'm hoping you got something out of it, but I would love to hear some questions and answers from and provide you the answers.
Gosh, I've seen you present before, and every single time I'm blown away seeing the chat and seeing the questions. And then even seeing our own Unite people saying, did you hear what he just said? This is incredible. So thank you so much. What you have to say is so worthy and valid and beautiful. All right, we'll start with some of these questions. And we have a number of them. So friends that are listening, we will likely not get through all of them. There are a lot of questions, but we will do our very best. And this first one is from Vanessa, and I think it's quite interesting. How do you recommend working with a patient resistant to seeing their pain as related to their emotions and nervous system state? Giving a little anecdote that he's very attached to being physically in pain, even though medically he's gotten a fibromyalgia diagnosis.
Fantastic question. And that is why in that 5 categories, protective mechanism, it's serving a purpose. Because if I have chronic pain, I don't have to deal with my emotions. I actually focus on the physicality of it. Here's how I would work with someone. I'd have them use the SSP for about maybe 5 minutes, or the moment they start to feel somatic sensations, I tell them to raise their hands and then tell them to pause. And then I ask them, what is it you felt when you listened to the song? So I'm using a backdoor approach of using bottom-up processing before I get to top-down processing, which is basically thinking. So in essence, I basically say, I don't fight when people are fighting, resisting like this is the truth. I basically have them focus on their body. When you listen to the song, what emotions came up, what did you notice that? And in having people use the cues of the body and working with the SSP, they eventually will shift. I've had multiple patients just like that. So keep at it and have a sense of hope. This will shift. But don't try to convince the patient. They will convince themselves.
It's beautiful. You touched on something that highlights a number of questions that have come. With your practice, are you giving the SSP to people and they're listening on their own? Do you require them to have a co-regulating other in the room, or are you in the room with them?
Yeah, great question. Depending on who it is, where it is, and the circumstances, For the majority of part, I try to have, it's a video, so I'm working remotely, and so they would be in front of me and I would have them listen to it. And they've told me they feel better to have someone in front of them. Now, if someone has a lot of trauma and is super anxious and overwhelming, I usually want to have someone in the room with them to be able to co-regulate. And I'll give them usually instructions like to turn to that person, to basically put one hand on your chest, one hand on your belly, and just drop into your breath, or to stand up with your hands. So basically to ground yourself. So, but for the majority of the time, my practice is usually on the video and I do it with them. I've done this in a group, just to let you know, like with anywhere from 12 to 20 people at once. And I usually have like a co-facilitator with me. And if someone feels overwhelmed, they will shift into a private room like in Zoom, and they will be able to regulate with them and then come back to the group.
That's beautiful. And that aligns so well with the way that we might recommend the SSP being used, and that it is an integrative therapy that goes alongside of other modalities and is best used in co-regulation with others. So it's beautiful. We have two questions here on acute and subacute, and wondering if you can just circle back to those 4 stages again, and if you have any references for that pathway that you were mentioning.
Yeah,
2 questions
absolutely.
on that.
I'll address the first aspect. So acute is basically anything less than 4 weeks. It doesn't matter whether it was a slip and fall or the pain, you woke up with pain, it doesn't quite matter. So that's what, by medical definition, acute basically means less than 4 weeks. Anywhere between 4 weeks to 12 weeks, so we can keep it simpler. Anything less than a month would be acute. Anything that goes beyond a month to 2 months to 3 months, so anything less than 3 months is what we call subacute. That's trend, and I'll talk about the transition shortly. So acute is less than a month. Subacute is anywhere from 2 to 3 months time span. And so that's what it is. And chronic is anything 3+. So from a medical standard perspective definition. Now, the stages are basically, there's a risk factor. We're marinated. So we have a stressful life. Our nervous system is maybe sensitized and a little bit more defensive and ready to kind of step in. And the second stage is the injury. So when you're pre-marinated with a sensitized nervous system, that injury actually is very difficult to calm down. That injury could be surgery, wondering, why am I not getting better? And so we've got the risk factors, the injury, the transition, and what makes the brain go from subacute to chronic are 2 factors. Is basically when you are emotionally distressed, like I fear the pain, I fear like I cannot stand this. And the other thing is I'm going to do anything and everything not to feel. It's intriguing, right? To heal, you are to feel from a therapy perspective. And then the 4th stage is basically the maintenance of chronic pain. And the cycle of that is called a learned neural pathway, which is a brain habit. The best reference I can have you do is actually Google, if it's the fastest way to do it, is Abkarian, A-P-K-A-R-I-A-N. Dr. Abkarian is world-renowned as the first person in the world to show how the brain changes. And he looked at the slide at the brain scans as opposed to talking to people. And he could predict with an 80% accuracy who will develop chronic pain. And the 2 factors, emotional distress or fear and avoidance, shifted the brain into chronic pain. So whatever we do when we fear and we don't have skills or the equipment to settle our nervous system down, we're destined for chronic pain.
Fascinating. We've had a couple of questions come up around the duration of time. You mentioned the 30 minutes over 10 days. Are there situations in which you might use or stretch that out a bit and do less of the SSP per day?
Yeah, great question. Working with a quadriplegic right now, from those who don't know what that is, they cannot move their hands, they cannot move their feet, they're in a wheelchair. It's a bad surfing accident. A young fella, 35 years old, has difficulty breathing. So, therapists are trying to slow their breathing down. So I basically came in the SSP, and he cannot stand it. When someone walks or talks, it overwhelms him. And all doctors did, like, maybe it's psychological. And I said, nope, it's the nervous system. So I basically got him to use it for 3 minutes. He could not tolerate 5 minutes. So we've been doing this for the past month. So I basically meet with him maybe twice a week. If you're not able to, I basically do small. And in that moment, he is listening to it for 3 to 5 minutes. I might stretch that out. It's not so much important, like, let's do this in 10 days. That's not the reason. We want to work with the person's nervous system. And sometimes it takes a little bit longer. A little goes a long way. Safety first, right?
So good. Have you ever used this, Les, for pelvic pain, or do you suspect it might be effective for pelvic pain?
Great. Simply a single answer is yes. Male pelvic pain, testicle pain, penile pain, women with pelvic pain, and even anal pain I've worked with and does. And it's amazing how it reduces the intensity of it, even when medical treatment. So I just want to be clear that this is not an elixir. It's we're using the Safe and Sound protocol to reduce the threat and to shift into what we call ventral vagal. So yes, it's very effective. And by the way, pelvic pain for most females is basically what I call a headache in the pelvic.
Interesting. I appreciate specifically when you said it's not an elixir. We would never want to come across as if we found the silver bullet. Yeah. There is none. And so I appreciate you saying that. It resonates. Alongside that, how long do you see the effects of the SSP taking hold? And are they ever, nothing is permanent, are they ever solid in someone's life, or does it shift back?
That's a great question. And that was one of my questions when I first started this. I thought it would last for a few weeks. For example, I said I've been using this about 2 years. I have patients who I treated 2 years ago and are still symptom-free. Now, mind you, these folks have very little stress in their life. They don't have a whole lot of trauma. Now, when people, I'll give you another example. I had a lady with pelvic pain and there was nothing reducing, and she was very suicidal because the pain was really bad. She didn't want to take opioids because it didn't allow her to function. Long story short, did the SSP, resolved the pain, and she was pretty much pain-free for 6 months until her husband yelled at her, which triggered everything. It was an argument they got into. So what I'm trying to say is it's not proof, but if you can learn to have skill sets, this is what the SSP is great. Lowers your defense mechanisms, gets you into safety, and then makes you more adaptable to psychotherapies and interventions. Long story short of this is it does last for a long time. And this is why the booster session, for those of you not familiar with it, there are 3 levels. There's SSP Connect, what I call pre-treatment. Then you have SSP Core, which is the treatment with the frequency. And then you have SSP Balance, which is the booster. And so when they basically, I have them, when they get done with the core, SSP Core, which is the treatment, I have them use the balance a couple of times a week, maybe 1 to 3 times a week for maintenance over a period of 6 months.
That's great. When you're approaching a client with the SSP, how do you go about educating, psychoeducating? How do you describe it to them? Do you have any hints or tricks of the way that you might introduce the SSP to someone?
Yeah, I steal from Deb Dana, and we all know and we all love Deb Dana, right? Just even looking at it and thinking about it, I get all warm and fuzzy. So I take from Deb Dana the ladder, and I often have someone who I'm speaking with, I said, to grab a sheet of paper and to draw a ladder, and then to draw a tree house as best as they can. And that's my addition to it. So I said, imagine, and basically explain to them the hierarchy of the nervous system as I showed the group here today, and basically tell them at the bottom, and keep it simple, when you're shut down, when you cannot fight or flee from your life problem, and when you're scared, I've used what I call the 3 S's: safety, scared, shut down. And then if they want to know like the science behind it, then I get technical, but I keep it super simple and jargon free as best possible.
Oh, that's great. And I can imagine it kind of runs on a spectrum, to your point, where some people will want those, I have a client that says, tell me the fancy terms. I want to know the fancy terms, which I appreciate. Okay, well, this is an interesting one, and it might dovetail off into a couple of arenas. Why would one, in your perspective, get stuck in misophonia from a trauma of a school shooting instead of chronic pain, as we think of it, and then vice versa? Also commenting that this is fascinating.
Yeah, thanks. It's what we still don't know is why the brain produces why it produces the symptomology. It's less about like the diagnosis. It's more about the nervous system. The nervous system, if you just take a general look, a 30,000 level look at this, the nervous system is meant to protect you in service of your survival. What's that mean? It basically means that it will produce certain somatic symptoms, and for those who don't like that word, it produces certain physical symptoms. the truth be told is whether it's ringing in the ear, whether it's sensitivity to visual or sounds or taste, I have several people, or touch of clothing, it's just the nervous system saying is me scared. And so what the nervous system says, so watch this, the nervous system says, let me keep you small and safe from the rest of the world. And I'm going to amplify a physical symptom in you so that way you don't have to deal with what you have to deal with. And I'm going to give you another visual. So in chronic pain, how I describe it with the nervous system is you're feeling these emotions rising. And the theory is this, is we've seen this, your emotions are rising and your physical pain will be higher than the emotions, so you don't have to deal with this. So whatever symptomology that's being expressed through the bodily system really is a state of defense. But if you go deeper and teach people how to be less fearful of what shows up, I'll give you an example, ringing of the ear or sensitivity of sound or sight. When you can learn to be in that sensation in a relaxed state, it actually reprograms the nervous system. So it's less about the diagnosis and it's more about the one system, the nervous system.
Yeah. And if you were to take that and follow it out, I mean, it's becoming back in relationship with your body in a way that's kind and it's like almost co-regulating your own body.
That's a perfect way of it, to be kind. And I gotta tell you this, is I've learned this through my personal experience, my patients, the recipe for this is to be super kind at the worst moments. And the reason it's hard to be kind, because physiologically it's nearly impossible when you're feeling anguish or fear, so be kind. This is where the therapy skills come in. And this is where the SSP allows you to have, this is why I'm going to say it again, the SSP does two things. If someone said, just give me 2 words, so what's this really about in chronic pain? I'll give you 2 words. It's exposure therapy. You're feeling what you're feeling. And as you feel what you feel in a sense of safety, you will actually desensitize the nervous system and reprogramming occurs. This is what's really happening, is exposure therapy and desensitization. When you can learn to be kind to yourself and relax into the worst state, that's when things start to heal. That's why you have to feel safe enough to heal. And so lower the threat of the nervous system and you start to heal.
So good. What questions or prompts are in the daily SSP log? A question from Heather.
And so I basically created it because for myself, and because when I asked my patients just to kind of they'd write paragraphs, and I have a lot of patients. I have like hundreds and hundreds of patients, and they email it to me, and so it's overwhelming. So I decided to come up with simple things, and being the psychologist I am, I wanted to simplify things. Basically, what thoughts you noticed shifted. I'll give you an example. I was irritated and with the song, and then when they got done with it, I noticed that I was able to be with myself a little bit more. So they realized the thoughts shifted. So again, where do negative thoughts come from? Let me walk you back one more time. Your physiological states determines your psychological states. So your negative thought comes from a sympathetic state. Calm the sympathetic, your negative thoughts change. So physiology determines your psychology in that sense. So with that said, I usually ask him, put down what thoughts you noticed that showed up at the end, what emotions you noticed at the end. And often it's, I feel more relaxed. There are some times during the treatment protocol of maybe the 8th day or the 5th day, they tend to say, I felt a little bit anxious. At the same time, they have the message that this is just a physiological state and they have control over it by choosing to breathe, going out and connecting and co-regulating, watching a funny video, going on and simply even moving your arms back and forth shifts your physiology. So thoughts, emotions, and physical sensations. What did you notice shifted in you after listening to the program? I just kept it simple. So far, it's been working and I get enough information. I usually want a sentence or 2 out of paragraph.
Yeah, that makes a lot of sense. It also makes me think that if someone is maybe stuck in their meaning channel or have over-exercised their meaning channel, it's another way to subvert kind of tuning into your body. And not that anyone would maybe be choosing that, but a subconscious leaning into the cognition.
Yeah, right on. And it makes it so fruitful for the session to go and to discuss, because that's what it is. The reason I have them keep a log is I want them to see it for themselves. That's 1. And 2, it's clinical information on where do I need to go with them. I'll give you an example real quickly. I was working with a scientist, and this guy is a real scientist. He's like, show me the proof. And And he said he started to, mind you, he had back pain for a year and he'd been to some of the best doctors. It was nothing less than 3 months that I was working with them. And specifically at the end of the first month after we did this protocol, he said when he was listening to it on the 8th day, he had a flashback of a childhood memory. And he goes, what was that about? That's a thought. And he was able to recognize that he hadn't been loved and he wanted to feel comforted. And so he realized when he did some of the mind-body practices that promoted a sense of safety, he noticed his pain dropped. And at that point, he realized that his past, his trauma really did impact. And so as we move forward with the protocol, we have him on video testimonial. A testimony basically shows that he goes, you need to feel safe to heal. By the way, let you know, he's back walking and he's pain-free. And he's 72 years old.
Going off of that, I know based on the chat and on some of these questions, we have a number of folks here that are experiencing their own chronic pain. And so I just want to acknowledge that. I think it's talking about it, but also I acknowledge that those that are experiencing these things are also listening right now, and that we're in your corner. Certainly, Les, you're in their corner. Let's pick another question. This is a good one. Are there any side effects that you've noticed of the SSP, and in which in that case, what side effects have you noticed?
Yeah, sure. Great question, by the way. Whoever asked that. I was not expecting it. Again, I was so oblivious to this. I was trying it out, and the only side effect I had, when I'll forewarn everyone, when you're in a state of defense, you've gotten into an argument with someone, you're at the airport and you went through the security check and they basically delayed you, and you're all fired up and wired up, and you put on the headphones, you will have the side effect. So do not use the Safe and Sound protocol when you are already in sympathetic. So which means that you're angry or really furious about something, or very anxious because of something going on in your life. Do not use that. That's the side effect you will feel. It will be amplified. So, safety over anything first. So I tell my patients not to use when they've had an argument with someone or a very stressful day with something, and they just feel like choking someone or crying or yelling, do not use the SSP because it only amplifies. That's my feedback. That's the only side effect I've seen. I haven't heard of anything else. And again, I get logs from folks, but I just want folks to know the other part is someone says, I feel overwhelmed with this pain. So as I'm listening to it, it's because if we do not take time to explain the theory behind it, the framework, we don't do the education, that will result in more of a side effect. Like, oh my gosh, as I'm listening to, I can see clearly now by Jimmy Cliff. And you're like, why am I having sensations in my nose and my tingling in my hands? So that means the provider did not explain. That's one. Two, there was no co-regulation to say, when you do feel sensations, it's normal to feel it. I want you to slow your breathing down. If not, you can gently pace back and forth or do a slow stretch. That seems to abate all of that. So proper prepping is good. But the other thing is basically do not use it when someone's overly distressed.
Yeah, that makes a lot of sense. Do you less use the SSP in conjunction with other therapies and modalities? I know acceptance and acceptance commitment therapy is on your repertoire, but do you use any other modalities alongside it?
Absolutely. I use IFS. And for those of you who don't know what IFS is, it's Internal Family Systems. It's by Dick Schwartz, basically going and talking to a piece of your mind or parts of your mind. I do use a variety of therapies, including mindfulness. What's intriguing on a side note here, because I'm not only practice mindfulness as part of my lifestyle, what's really intriguing is people tell me that they meditate a little deeper. What that's worth is they tend to feel a little bit more in touch with what shows up. So I do use a variety. My main staple is mindfulness, acceptance and commitment therapy, and internal family systems. So I do use that a lot. Now, the other thing is for exercising, physical therapy stuff, they seem to be more committed to it. Even when they feel overwhelmed, they're like, wow, I'm feeling a lot of pain as I'm exercising. There's less fear. Remember the two factors, fear and avoidance? Well, it's almost like we're reprocessing that. So that's my best feedback.
Yeah, it makes a lot of sense. Have you noticed that there's different success rates based on different demographic groups based on your research? I'm also getting a number of questions around the BIPOC community and how it relates to the ACEs scores, and if you are treating that community as well.
Repeat again, what community? I didn't quite hear that. So.
BIPOC.
Oh, fine. Yes. And so so here, my main population I treat is basically patients with chronic pain, and a lot of them do have ACE because I do ask about that. What I do know is the greater successes come from when people who, it doesn't matter how high your ACE is or what kind of population you come from. Probably the most important thing I can emphasize is that it's still the same system. But I will tell you this is, I seem to have greater success with those who have less chaos in their life in the present day.
Mm.
It doesn't matter whether you're male, female, LGBTQ, it doesn't quite matter what population or who you are, but when there's a lot of chaos in your current life, you're not dealing with it. And that's something I talk to my patients about is take care of your life. This is not an instrument to be used to avoid your life. It's meant to actually empower you with a sense of hope, right? So that's where the narrative of hope comes in. So you can actually, it's a means to an end to the therapies that really work well. Physical therapy, the psychotherapy stuff, exercise, dietary. People with weight loss, I seem to have greater commitment to weight loss. People who are really, really obese seems to actually help them keep with the dietary. Again, it goes back to, it doesn't matter who you are, and what you bring. It's your nervous system think of it as a dial. How intense and distress is it? And the SSP basically just drops the intensity and shifts you into a state of safety, which then promotes health, growth, and restoration, just to quote Porges.
Yeah, it's interesting. How would you, because what I hear you saying is that it's important for someone to be resourced prior to maybe engaging with the SSP, so that experience of safety has somewhere to land with, given their environment or relationships with others, with themselves. How might you recommend someone resource themselves in order to be ready to engage with the SSP?
Yeah, great question. One of the most important thing here is if there's something very distressing in your life, it's connect with a therapist or psychologist. Mm-hmm. The reality is I highly recommend this. There are no shortcuts. So the reality, and also if you don't have a trauma or something very distressing, if someone's going through a divorce, if someone has got a death in the family, seek the people and the professionals that can help address that issue. If you have financial problems, take a look and see, what do I need to do to kind of rebalance my life, the way I spend money, or what do I need to do to get in my financial situation balanced? So look at your life and see what needs adjusting, then come to the SSP to be able to learn to shift your nervous system. So I'm going to say it in a very simple term. Do not run from your reality. Embrace your reality with the right resources and the professionals.
Mm-hmm. Yeah, when you've looked at the cases that you've seen, what is the timeline? So someone's ready to use the SSP, they've started to use it, and knowing that there's no one right timeline, what is the timeline that someone might expect to start feeling better?
Yeah, great question. So excited. I get giddy about thinking about this. I was actually surprised. So I'm just going to tell you, based on my experience and hundreds of patients I've seen, I was actually blown away. So this is truth be told. I was actually blown away by the end of the first week. After 10 days, they're actually reporting, "Oh, I feel better." I'm like, "Oh, that wasn't the treatment. That was the SSP Connect." So so here's how I do it. Is initially I was just using the SSP core to treat someone with chronic pain, or if they have trauma and chronic pain. I found out that I need to develop a relationship with this, not only the nervous system, but with them. And very often people don't tell me everything. And so I really don't know unless they tell me what they tell me. So moving forward here is I usually start with the SSP Connect. At the end of 7 to 10 days, I actually get emails telling me, and the log says, I actually feel a little bit more relaxed. So are we all done? I'm like, oh, no, we're just getting started. So I see, and the number one thing that's reported is basically I feel less anxious after the SSP Connect. So, and it's even better after SSP Core. So. And
would you dip right into SSP Core? Do you give some?
Great question. I usually try to, depending on it. So it varies, but very often I would like to, we'll sit there and discuss I usually want to give it a few days, maybe anywhere from 1 to 3 days, just to let the system settle as opposed to just get back in there. I think space in between everything else, much like life, if there's a little bit of space, it's good. More is not always better. And plus, I'd like them to be able to experience it. And this is kind of a cute note. My patients kept on telling me, hey, my spouse is finding me more attractive. I talked to Clovis about this. So one of my patients overheard another patient talk about that. He goes, I wanted the SSP so my wife can find me more attractive. So we're not using the SSP to manipulate your spouse. So,
oh my gosh.
Yeah, it does. And that's the thing, is because people who are feeling less defensive smile, they tend to have this tone of voice that's different, as Porges talks about. And I told Porges about that, and he just smiled. So yeah, people find, you may not notice the difference of the anxiety coming lower, whether it's the SSP Connect or SSP Core, but people around you will say, hey, are you on a new medication? Hey, you look great. Did something good happen to you?
How do you engage SSP balance, either on the back end or throughout?
Yeah, great. And usually when they get down with the SSP Core, I usually have, again, a little space in between, maybe several days to a week. And then I basically tell them so the SSP Core, I usually want them to use it, a couple of times a week. A lot of my patients are very rigid and regimented. Now, I'm going to use it every single day. And I said, this is not meant to be intense. So I usually prescribe anywhere from 10 to 30 minutes. I want them to have control of their life. And this has worked really well. Initially, when I started about a year or 2 years ago, it was like, all right, 30 minutes for 10 days. And I found out that that's not helpful. I found that it's better to do small dosages a couple of times a week, and it seems to maintain them very well.
That's great. Do you mind repeating the mantra that you stated at the very beginning with the breath work?
Oh, sure. Right here with the in-breath, right now. So whenever my mind wanders, or when my nervous system gets into the sympathetic state of, like, I'm right and someone's wrong, or whatever it is, or I'm finding myself getting irritable, I notice a mood shift in me, which means my physiology has shifted from safety to sympathetic. I basically will repeat this mantra, a soft mental note, right here, right now, right here, right now. I do that over and over until I find a shift in my system that's now into the ventral vagal. So,
gosh, so good. We have one more minute, and the last question I would love if you could take a crack at it is, if you could have those listening today walk away with just one idea, phrase, knowing, what one thing would you want them to remember from what you've said today?
Absolutely. I think that's a lot I'd love to say, but in simplicity here, I probably would say is the Safe and Sound protocol, without a doubt, is an avenue towards safety. And you cannot heal until you feel safe enough. So think of the SSP as the science of safety in action.
So good. Well, that it wraps up our time together, and just grateful for you all to be here and to engage and ask questions. Les, thank you so much for just the work that you're doing. Is necessary and powerful and beautiful. I'm going to go ahead and share my screen with a couple more notes. If you guys have, those listening, if you have any questions about the SSP specifically, we have a webinar that's going on tomorrow called Simplifying the SSP. It's at 12 p.m. Eastern. The link for that will be put in the chat. So if you're a provider, psychologist, any credential, OTs, PTs, you're welcome to attend that webinar and learn a little bit more. And you're also welcome, if you're interested in using the SSP with your clients, to book a call with our provider, our program consultants directly on our website. Again, a link for that will be in the chat as well. But Les, thank you. We appreciate you. We're thankful to have you a part of our community, and thank you all for attending. And you're welcome to reach out to us with questions or anything else that might be helpful or supportive to you. Thank you so much. Bye, everyone.